This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
Hi, I'm Dr. Randy Martin. I'm here at the AHA in Chicago, and I'm pleased to be joined by Dr. Leslee Shaw. Leslie is at Emory University in Atlanta and has just presented some fascinating data on what's called the Women's Trial. Leslie, this deals with how do we diagnose coronary artery disease in women. Tell me a little bit about the trial.
Well, as you know, Randy, is that the diagnosis of coronary disease in women is very tough because we really don't have a clear insight in the pathway into what is the best diagnostic test. As a matter of fact, a lot of observational data have shown that the exercise ECG is associated with a poor accuracy in women. So we undertook this women's trial, what is the optimal method for evaluation of ischemia in women, in order to look at the exercise ECG as compared to myocardial perfusion imaging with the mindset, would there be an added value in perfusion imaging due to the observational data showing a low accuracy. We randomized 800 women to an exercise ECG versus an exercise ECG plus myocardial perfusion imaging from about 40 centers across the U.S.
And Leslie, these were, so we're talking about women with low to intermediate risk of CAD, and were they, the obvious question, were these perimenopausal or postmenopausal women?
Well, most were postmenopausal, but the important consideration here is they all had to be able to perform an exercise test. So they were low to intermediate risk, had good functional capacity, and that is the rate limiting, that's the most important point in terms of our take-home message. If these were women who can exercise. So we're not talking about people who belong at pharmacologic stress imaging or those with poor exercise capacity.
So I'm sorry for cutting you. I understand what you're saying. So these, tell me a little bit about what were the results? So I mean, how many? I've looked a little bit at the slides that you presented this morning. Tell us what the results were.
Sure, it's interesting, and I think they would support a lot of our prior knowledge of the ECG. About a third of the time, the ECG results were abnormal. And in the women who were randomized to perfusion imaging, only around 10% of the scans were abnormal. So it's an interesting result. We still have this concern about a high rate of false positive testing in exercise ECG. However, when you look at the follow-up study, the 2-year event-free survival were similar between two arms. There were no different. There's no benefit in terms of adding myocardial perfusion imaging on top of the exercise ECG in terms of 2-year event-free survival.
So this is really contrary to what many of us think in clinical practice, that we need to go right to a perfusion stress test.
And I think it is the lion's share of women that are evaluated, even these low-risk women that are sent to a perfusion scan. Interestingly enough, in many cases, the women who had abnormal tests often went to what we call a crossover perfusion scan or a downstream perfusion scan. So what we're encouraged by the results of this trial is not necessarily that there were no difference in outcome, but to use the ECG as an ECG first strategy, similar to a lot of trial strategies. We're talking about the ECG first, followed by selective myocardial perfusion imaging in those women if you need it.
So the cost effectiveness of this would be dramatic.
Dramatic. We had almost 50% cost savings between the two arms. And I think that's an important take-home message in our healthcare, where we are doing so much testing. We need to do a better job of identifying appropriate candidates for imaging.
Super. It's a dynamite study, and I appreciate you sharing it with us. And so, because I think this will change our practice modalities. So, Leslie, thanks for joining us.
Thanks, Randy.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource video news at AHA 2010.